Welcome everyone, and I want to welcome you to today's program. What we're talking today on is Joint Commission, also known as the Joint Commission, the National Patient Safety Goals. I want to give you some very vital information. Doesn't matter if you're an acute hospital, a critical access hospital, whatever the size. These apply across the board. So I have four main objectives for today's program. Number one, we're going to talk about some of the revisions that they did make to the goals. They went into effect January of 2022. We're going to talk about how Joint Commission allows for verification for blood administration by one person. All you have to do is barcoding. And then what are the 5 medication reconciliation standards? Because we still have issues with that. So overall, National Patient Safety Goals, what they decided to do, what the overall goal was, to move away from that very prescriptive requirements. All right, let's go ahead and start talking the goals. Now, I did mention these apply across the board. Now, there are certain ones and certain information in the hospital ones you will not find in the critical acts. I'm going to point that out. But for hospitals, well, let's start with patient identifiers. Our goal, first off, is to improve the accuracy of identifying those patients. Use 2 identifiers when you're giving the care. Critical test results. Here, what we're talking about essentially is communication amongst us caregivers, that we report those test results and diagnostic procedures timely. Because those test results, critical tests, that's way outside. Well, medication still continues to be an issue for us too, and in particular, labeling medications. That's containers, syringes, other solutions, and that's both on and off the field. This is in perioperative and other procedural settings. And I've got a good example of this one. I was working pain management, and the way the process did, the way we set it up is the nurse would get the patient ready, and this was usually for, like, say, an epidural steroid injection. So we got the IV started to help them with some sedation if that's what they wanted, got them on the monitor, and then we had them sitting up on the side of the bed. This was after, of course, all consent was done. And then the physician would come in with having their medications. Sometimes they would draw them up at that time. Sometimes they would come up with them already drawn up. Well, the nurse also had their medications drawn up, and that could include a saline flush if there wasn't an IV running. Medication reconciliation is our next one. That's just goal number 3. Having more than one medication is not that uncommon, especially as our populations age. We start taking many more medications, and we sometimes don't even have to age to have them. The complexity of managing all those medications make reconciliation crucial. That's a very important safety factor. Overall, what they're doing, the clinician, could be an RN, they compare the medication the patient should be taking and what the patient is actually taking. We want to also look at the new medication order. Are there any discrepancies? Is there anything that's like, well, no, you're not supposed to take this with this new medication. Stop that. And they go back. That's why they have now prohibited that resume previous medications order. Medications are done. Let's move on to alarms. Any of you who have ever worked in a clinical setting, say an intensive care unit or an emergency department, some unit where you have alarms, patients who are on these monitors, sometimes start to tune out alarms. We don't hear them, or we don't heed them, because I also believe that's a portion of not being able to hear it. That's why goal number 6 is to improve the safety of our clinical alarm. So alarms it's a huge patient safety factor. I always think the alarms are there for a reason. Why would I shut it off? Healthcare-associated infection, HAS, specifically hand hygiene. You may have seen this picture. This is on slide number 94. This is your unwashed hand. This is your just plain hand. Under blue light, you can just see how sad it is on what's still there. And then we have the goal on preventing suicide, and this is within your facility. And again, that special report on preventing it within the hospital or clinical care setting. So as we start coming to an end here, I want to talk about universal protocols. In other words, timeout for your procedures. Procedures, surgeries. Patients are most at risk during general anesthesia or really deep sedation. So you can enhance safety, correctly identifying the patient, what procedure is going to be done or scheduled to be done, and where. The site. It can occur more than one time, more than one place. You determine when the information is collected and who is going to do it. And of course, it's always best, again, when the patient can be involved. So they're aware of what was discussed, because sometimes I bring them, no, you're doing my right eye, not my left eye, and how you would tap into it. Some of the goals that hospitals have, what they put up when they're going for National Patient Safety, especially National Patient Safety Week. So again, thank you everyone for attending, and stay well. This will conclude the program.